neuroscience has arrived and is alive and well at the Neurocognitive and Behavioral Institute. As part of each patient's neurodiagnostic evaluation, we integrate clinical data from multiple neurodiagnostic procedures. This typically includes quantitative structural brain imaging with functional brain mapping using the latest technology in fMRI, electrical neuroimaging, cortical functional assessment, and autonomic nervous system testing in order to target brain regions responsible for each patient's symptoms and deficits. These targets are then manipulated using non-invasive, high-definition neuromodulation interventions, which is one of our clinical specialties at the Institute.
Hello, this is Dr. Tramontano, the Medical Director at the Neurocognitive and Behavioral Institute. And today's presentation is going to focus on the diagnostic and treatment services offered at the Mind Body Neuropsychiatric and Mental Health Center. This is one of 5 centers at the Institute, and today we're going to focus in a little bit more on what the services are related to this center and the type of patients who are treated at the center. Okay, so patients coming in to the Mind Body Neuropsychiatric and Mental Health Center will almost always receive a pretty comprehensive psychiatric assessment. We tend to use one or more versions of the SCID that's based off of the DSM-5. And in addition to that type of psychiatric examination, patients will often receive various forms of psychological testing to assess what type of mood disorder they may have, the severity of those mood symptoms, whether they're related to underlying types of conditions such as axis 2 or personality type disorders or temperament-based trait type of disorders. So that all gets teased out in the psychiatric assessment. A lot of patients presenting, for example, with various forms of anxiety disorders such as generalized anxiety, separation anxiety, post-traumatic stress related disorder. A lot of those patients receive what's called autonomic nervous system testing, which tells us what the tone of the autonomic nervous system is like. So for example, the autonomic nervous system, one way to conceptualize that is a parasympathetic or a relaxation type of branch of that older nervous system. And the other branch tends to be an activation or a sympathetic branch of the autonomic nervous system. Patients with anxiety disorder, not all, but many will have excessive sympathetic reactions, and often that guides treatment in a certain direction to try to decrease those strong sympathetic over-arousal type fight, flight, and fear reactions. So that's important testing to do that differentiation. And as you'll see later in the presentation, there are treatments that are directed at that level, at the autonomic nervous system level, to try to give patients relief. I'll show some examples of how we use neuroimaging, such as electrical neuroimaging and functional MRI, to help with the diagnostic workup and teasing apart what might be going on with the patient and how best to treat their symptoms and deficits. Related to the autonomic nervous system testing is what's referred to here as biological testing. We'll fairly routinely do neurotransmitter analysis. Now, to really get an accurate assessment of neurotransmitters such as catecholamines or serotonin, you really need to do a cerebrospinal fluid analysis, but that requires a lumbar puncture, which for this purpose we often don't do that, so we use 24-hour urine collection to give a rough view or assessment of neurotransmitter activity and potential deficiencies or over activation of certain neurotransmitters. So it's not super accurate, but it's helpful in guiding some of the treatment decisions. Neuroendocrine, this is typically adrenal function and thyroid function testing. Generally, we do the adrenal function testing through saliva and the thyroid testing through blood. Micronutrient testing, this is often related to vitamin B1, B6, B12, folate, zinc, copper, magnesium. Also can play a role in certain neuropsychiatric conditions. Another type of testing that we offer at the Institute is what's called pharmacogenomics. This has become pretty popular over the last several years to give a look, an assessment of how a patient may be metabolizing certain medications. We could run the panel for different psychotropic drugs in this case for patients coming into this center. But once you have your genetic profile, any doctor can use that information for any type of medication to see how well you may be metabolizing a certain type of medication based on your genetic profile. So these are some of the assessments that we use fairly routinely in working up patients who come into this center. So with these various diagnostic tools that I just outlined, we can get at better differential diagnoses. So for example, some of the more common presentations are major depressive disorders, and our ability to separate that from a much more common type of depression, which is a persistent depressive disorder, sometimes referred to as dysthymia. And certainly some patients, a fair number of them, will have double depression, meaning that they've had clear episodic major depressive disorders, which have really interfered with their functioning at times when they're in these episodes, but have also had long and lingering persistent type of depressions that do not meet criteria for major depression, but still are interfering with their functioning. And this is important because they're treated differently. So, for example, in major depressive disorders, particularly some certain subtypes of major depressive disorders, pharmacotherapy can be very effective. Neuromodulation types of therapy like TMS or TDCS can be very helpful, particularly if we can see neuromarkers that some, maybe 20-25% of major depressive disorder patients will present with, versus a dysthymic disorder, which generally doesn't respond very well to pharmacotherapy. Sometimes you may get some symptom relief from Wellbutrin, or even SAMe has been shown to have some a little bit higher efficacy in treating dysthymias, but in general, pharmacotherapy approaches work less well. So knowing the difference of what type of depression a patient has is very important in terms of guiding the treatment and even the rest of the diagnostic workup. Same thing for more generalized anxiety disorders, which I mentioned a little while ago. These tend to be more trait-based in that if you come in to the world as an anxious person, you're generally going to have a high level of anxiety more or less throughout the lifespan. And these patients generally meet criteria for generalized anxiety disorder, which is probably the most common psychiatric disorder, at least in this country. And that's separated from other types of anxiety disorders, for example, agoraphobia with panic attack, and again, treated differently. Obsessive compulsive disorders versus obsessions, which can generally result from anxiety disorder, versus compulsive behaviors, which sometimes can be coping mechanisms or sometimes secondary to anxiety disorder, but may not necessarily be an obsessive compulsive disorder, which again tends to have pretty distinct neuropsychiatric and neurocircuit types of abnormalities that we tend to look for in obsessive compulsive disorder in an attempt to manipulate the abnormalities in those circuits, which you tend not to see those types of abnormalities in patients who have secondary obsessive or intrusive thoughts, for example. And also, as I mentioned a little while ago, access to disorders, or the more trait-based disorders, or sometimes these referred to personality disorders, again, can be very helpful. We very often see patients with orbital frontal limbic dysfunction, for example, present with a lot of mood instability or affective instability or moodiness, emotional lability, that type of presentation that they may have had for a very, very long stress. Of course, it gets worse, but they don't meet criteria for a bipolar spectrum disorder. And again, the two are treated very differently. So these types of differential diagnostic workups are very, very common for pretty much every patient that comes in to the center. And as I mentioned, it begins with a good history, a good psychiatric exam, and a lot of neurodiagnostic type of testing. Okay, this is kind of a busy slide, but the point is there are ways to use psychological testing to help tease apart, so to speak, the different types of presentations that patients will present with. Everything from how much they seem to be disclosing or how much they seem not to be disclosing. Um, they over disclosing, over reporting their symptomatology, and why is that the case? How much access to, or what's referred to as trait-based um, psychopathology contributing to their problems versus a state-based type of, for example, mood disorder. So the psychological testing does a really good job in helping separate that, and this is very much directly related to the type of treatments that they're going to receive, even in terms of the type of psychotherapy that they're going to be treated with. So the psychological testing and the psychological profiles are very helpful, and we use those pretty much with every patient that gets evaluated. So as I mentioned earlier, autonomic nervous system testing. So just a quick layout. The cortex is basically the top part of the brain that contains a lot of our cognitive functions, attention, learning, executive functions, our ability to do math, our ability to be conscious and aware, very much cortical based. And of course, the cortex is wrapped over the autonomic nervous system, connected to the autonomic nervous system by a bunch of fibers down in the base of the cortex, and then the autonomic nervous system is represented in the brainstem and the limbic system. And in the limbic system is your mood center. And you're not going to get a great assessment of pathology in the autonomic nervous system by just looking at the cortex or just having the patient fill out, mood related measures or personality related measures. So we try to, as best as we can, non-invasively, assess what's going on in the autonomic nervous system. And there's ways to do that. And of course, in patients who we suspect that there may be hyperactivation in that system, such as hyperamygdala responses, the amygdala structure is what is responsible for our fight, flight, fear, freeze type of responsiveness. And it's, of course, tied to our survival, so it's very vital. But it also can be highly tuned, and sometimes, for example, from trauma, can activate the amygdala and put it on high alert for the rest of its existence. And that's very much difficult to control, as the name indicates of this type of nervous system is very automatic. So when we're trying to assess for that hyperactivation, that elevated sympathetic tone, there's ways to do that by looking at, for example, blood pressure changes or heart rate changes or electrical dermal changes, which are all very good measures of autonomic activity. And we'll do that under some, light stress conditions like sitting down, standing up, squeezing a dynamometer, doing some mental arithmetic. And in patients that have, very overactivated amygdala responses, we'll see, significant changes from baseline through what sounds like, relatively benign types of tasks, and it just will show how quickly and how active the amygdala responds to these types of stressors. And these are the patients that we tend to do some neuromodulation of the amygdala, again, non-invasively, and we'll talk a little bit about those treatments for patients to decrease the activation of the amygdala. So the amygdala, as I mentioned, is a key structure of the limbic system, and it's in direct communication with a structure called the hypothalamus, which is in direct communication with the pituitary gland, and that is in direct communication with the adrenal glands, which pushes out those high levels of emergency responses in cortisol production, and all that happens very, very quickly, 30 milliseconds. So way before it can get to your level of awareness, which is a good 200 to 300 milliseconds away. So to treat those types of disorders, you do have to treat at that level. So we'll talk about some of the treatments in the next couple slides. Okay, before we get to some of the treatment, I also wanted to show a little bit of how we can use neuroimaging to also help with the diagnostic workup. So this is a patient who came in complaining of attention-related problems, and when we evaluated the patient, we can see some of those attention-based problems, but that doesn't tell us, where it's coming from. So this is where, neuroimaging, as I just mentioned, autonomic nervous system testing could be very helpful. So in this case, what you're looking at here down in, the limbic system, this is the brain kind of tipped upside down. It's a three-dimensional view, and you can see these kinds of hyperactivation in the left orbital frontal cortex back into the limbic system. This is a two-dimension view of those hyperactive connectivity. But if you look up at the main branches here in the right frontal parietal cortex, there's no pathology. So in patients, for example, who are having attention problems, this is a good way to tease apart that it's likely coming from what's called the inferior, the low branch of the attention network, which transverses right through the inferior orbital frontal, ventral frontal medial cortex back to the limbic system, as it should, so that if something threatening happens, we can attend to it and execute a very quick response. So, of course, we have branches from these very cortical networks like attention and executive going down through communicating with other areas of the brain. And when there is pathology, psychopathology, such as depression pulling down, so to speak, on those attention executive networks, you can get cognitive changes. Same thing, for example, for anxiety. It can interfere and ripple, kind of high short-term activation throughout the attention network and kind of wreak havoc with the patient's capacity to stay focused and stay on task. It's a common question that we get all the time at the Institute, and trying to differentiate, what's causing the cognitive problems, and more importantly, what we can do about it. And autonomic nervous system, cortical assessments like this play a nice role in developing a treatment plan and targeting where the problems are coming from. So in this case, not only treating the anxiety disorder, but hopefully also improving attention. So this would be an example, for example, with a patient with attention problems. But this time you see there is cortical slowing, in this case, in the right dominant dorsal branch of the attention network, where you can see these crosshairs, as well in the prefrontal cortex and in the left prefrontal parietal network, which is a major branch for executive dysfunction. So again, this is where neuroimaging can, it's pretty easy to do, non-invasive, and can really differentiate. Is the attention in this example coming from those higher level dorsal branches versus what I showed a little while ago, where the dorsal or upper portion of the cortex was nice and clean, but down in the limbic, orbital frontal limbic areas, you can see some of the connectivity abnormalities. And in electrical neuroimaging, that area connectivity maps can connectivity mapping can do a nice job in differentiating the two different types of problems. And in the next slide, I think I'll show you a patient who has both. So in this example, this would be another patient presenting with attention deficit with anxiety. So not only do they have the hyperconnectivity in the limbic system and with the ventral frontal medial and orbitofrontal medial cortex in the inferior, the base part of the prefrontal cortex, you can also see up in the higher areas of the brain. Again, this is a darker color in red here, showing that it's almost 3.5 standard deviations away from the normative database, again, in those right dorsal branches of the attention network, and also in the left branch, which is very dominant for executive function, and you can also see in the medial prefrontal cortex as well. So this would be a patient that had presented with attention deficits, and even if you treat at a lower level of the brain, so to speak, and decrease that hyperactivation from, let's say, anxiety, we would expect that you're still going to have, left over, so to speak, attention problems, and then the treatment would have to be targeted at these higher levels. I think there's a presentation that that's on our website that also talks about how we treat, cognitive disorders. So you might want to check that out if you're interested in learning how those higher level cognitive disorders are treated. Another useful role that electrical neuroimaging can play. We do a lot of electrical neuroimaging at the Institute. It's, non-invasive, it's quick, it's easy, particularly for children or older patients. You don't have to go into an MRI tube. And it's been around for a while and just keeps getting better and better as the software and technology, continues to improve. So a role for electrical neuroimaging is predicting antidepressant response. And that data has been around for actually a very long time, probably dating back to the late 70s even. And this would be an example, patient who has a very nice, alpha production in the cortex. And, generally patients with good alpha production usually respond, well to antidepressant medicines, where those that have alpha deficiencies tend not to respond as well. So again, another helpful differential that goes into the treatment planning. I talked a little while ago about, particularly with autonomic nervous system evaluation, where we'll look at neurotransmitter analysis, which can be helpful. Sometimes we'll see excessive histamine activity, which is a activating neurotransmitter, or in some patients, for example, patients who have a long history of anxieties, and when they hit their 40s or so, the adrenal cortex is starting to burn out a bit. You get what's referred to as adrenal fatigue, and you can actually see a decrease in cortisol production. So cortisol neurotransmitters, they play a role. Thyroid, as I mentioned, also plays a role. Hypo and hyperthyroidism can present with a lot of mood-based symptomatology. It's a fairly common evaluation, so most patients do get that, even outside of our institute. The micronutrient analysis, that's something that's a little less common. We'll see it done more in geriatric patients presenting with cognitive problems, but it also plays a role in mood disorders, particularly copper analysis, in some disorders that don't clear enough copper, and some of the zinc deficiency based disorders can also present with a lot of neuropsychiatric complications. So some patients ask why do we do cortical functional testing? In other words, assessing, the higher levels of the cortex, which I was showing you in a few slides ago with, tests of attention, executive function. And the reason why is because the cortex, as I mentioned a little while ago, particularly the lower portions of the cortex, are very much involved in emotional and behavioral regulation. So that link between the higher brain and the kind of mid-lower brain structures like the autonomic nervous system is very much a cortical functional test. So our orbital frontal cortex and our ventral frontal medial, our ventral prefrontal medial cortex, very much involved in our ability to regulate our emotions, regulate our impulses and our behaviors. Also very involved in social pragmatics in terms of our capacity to behave and interact normally in social situations. Ability to learn from our mistakes, also very much guided by those same lower inferior frontal structures. So when you're doing neuroimaging, you can't just look at the neuroimaging, you have to see if there is cortical dysfunction, because you need to do that first to create a hypothesis about what you're likely to see in neuroimaging, and then either confirm or disconfirm those hypotheses. So cortical functioning, particularly patients who are presenting with good cognitions, good cognitive abilities, will often see, if they have a long history of emotional behavioral dysregulation or interpersonal difficulties, in a good chunk of those patients we will see lower inferior prefrontal limbic types of either connectivity abnormalities or sluggish, what's called sluggish regulatory hubs. So typically we'll see that in many patients, and without doing the cortical functional testing, we're not going to be able to diagnose that. And we'll miss that, and of course we'll miss an opportunity to treat that. This slide is related to what I outlined earlier, the pharmacogenomics. And very helpful, very useful, particularly patients who are on drug therapy for the neuropsychiatric condition, or thinking about changing their medications, or maybe not responding that well, or have had a lot of side effects from their psychotropic medication. So this is just a snapshot where you give a saliva sample, and the lab sends back the different medications. If you run it, for example, for psychotropics, the different medications, and how this patient's genetic profile interacts with those medications. So you can see on the right side the number 1 indicating that the blood levels may get too high for a lot of these medications that are on the left side, like doxepin and Prozac. And so lower doses may be required, particularly for something like Prozac, which has a very, very long half-life. So this is very helpful in terms of which medications maybe to stay away from, and if a particular medication is going to be used, to help the prescribing clinician dose that medication appropriately. Okay, so does all this diagnostic testing improve outcomes? And so the answer is that if you're going to do the diagnostic testing, treatment outcomes are going to be improved if you address the treatment planning at each of the levels where there's deviations or abnormalities. So, for example, if you have a patient with very high sympathetic tone on their autonomic nervous system testing and have severe levels of anxiety, and you're only introducing to them, a cognitive behavioral form of therapy, which can be very helpful in helping them cope and rationalize and behave in other ways, and kind of back themselves into a less anxious lifestyle, all very useful. But you still are going to have a hyperactive amygdala, and that's going to need to be addressed. And yes, sometimes the cognitive behavioral therapy can be effective in changing that, but you also probably want to think about directing treatment at that level. So depending where the problems or severity lie in the different systems, autonomic, cortical, like I mentioned, in terms of behavioral regulation, biological, such as adrenal functions, psychological, in terms of, maladaptive coping mechanisms or defensive mechanisms. So as all this stuff becomes evident from the diagnostic workup, then a treatment plan is built around those findings. And if you do that successfully, patients are going to have better outcomes. And it's not like they have to have multiple treatments. Sometimes one or two treatments will target the different levels, but you got to know where the problems are and, figure out if that one or two treatment is going to address all of the problems. Otherwise, you're only going to get a partial response to treatment. So this slide just breaks down some of the general categories of what's referred to as mental health therapies. You have your psychological therapies, which are your talk-based therapies, working with, psychotherapists. Of course, cognitive behavioral therapy has become very, very popular over the last 30, 40 years. Um, social interpersonal types of therapies have also become popular. So even psychodynamic focused therapies, trying to, make patients more aware of their kind of, just unconscious impulses, things that happen under the hood, so to speak, that's just guiding all of their decision making to try to, lay that out for them, put it out on a table, so to speak, where they can see it, so they have a kind of a fighting chance to do something about it. And so there's still, a huge role for psychodynamic focused therapies, particularly as we learn more and more about cognitive neuroscience, showing that, pretty much, the cortex is a Monday morning quarterback, so to speak, in that, our decisions and our, capacity to run our life is very much, 300 milliseconds behind our level of awareness. So, the psychodynamic therapies, which, date back, over 100 years, and can be very, very useful in the light of new findings in cognitive neuroscience over the last 30 years. So, huge role for psychotherapies, I think, in every mental health treatment. The behavioral therapies, these are less talk-based therapies. These are, manipulating, triggers or antecedents, manipulating consequences of behaviors. There's definitely a role to integrate that into, many patients' treatments. Psychotropics, your anti-anxiety slash antidepressive medications, your antipsychotic medications, and what's termed non-invasive neuromodulation therapies, which, patients may be familiar with some of the invasive forms, like ECT, electrical convulsive therapy, is an older form that's called invasive because you have to, create a seizure in the patient. You have to use anesthesia and benzodiazepines during the treatment. But now there's newer forms of, non-invasive neuromodulation where you're not pushing 800 to 1,000 milliamps into the patient's brain, but using 1 to 2 milliamps to gently manipulate or modulate, neurophysiological circuits. And this is a big area of interest for us at the Institute. We do a fair amount of research in this area and a lot of treatments using, different types of neuromodulation interventions. And I'm going to talk a little bit about that in some of the upcoming slides. So this is a setup using a neuromodulation type of intervention. Now in the clinic, we're using caps and gels, and we configure based on the patient's MRI results and what's called target optimization, how we're going to configure the different sensors to emit a wave into the cortex or subcortex to, turn it up or down depending on what we're looking to do. But these home devices that are approved for, like anxiety or ADHD, they're much simpler to use, but this is just showing you the setup, in the clinic, because we often will try these interventions out in the clinic, make sure they work, and then ultimately try to get the patients a home device to use in the home environment so they don't have to keep coming into the clinic for their treatment. So this is an example of a neuromodulation device. Again, you can see the sensors set up in a certain configuration based on what we call target optimization. That's a lot of software-driven metrics. This is the unit that, generates the different waveforms. So it can generate, a sinusoidal or alternating current type of wave, a direct current type of wave, a random noise, different interferential types of wave. All different types of waveforms can be used. And again, this is a clinical research device, so we can create these different protocols from this one device. And like I said, some of these treatment protocols or slash medical devices have already been approved for a number of different conditions. Cranial electrical stimulation has been around since the 1970s for anxiety, insomnia, secondary to anxiety, and even depression. And they weren't very super effective. They had a little bit of efficacy, I think, for anxiety more than anything. But the newer devices are much more effective, can be much more focal. They don't use sponge-based electrodes, so they don't have such a widespread or dispersed type of waveform. So the technology has become much better. Tend not to use the terminology cranial electrical stimulators as much. Neuromodulation tends to be the more in vogue term. But these devices have been approved for anxiety, tinnitus, like ADHD, post-stroke hemiparesis, opioid withdrawal. So they're getting more and more popular, I guess you could say, and they're really easy to work with. The side effect profile is very low. Unlike a drug, it's not broad-based. It doesn't affect the kidney, livers, heart, pulmonary system, GI system. So side effect profile is much more favorable. Uses very, very small amounts of current to generate the waveform, so it's usually very easily tolerated. So there's a lot of potential in neuropsychiatry and of course in cognitive neuroscience for these types of treatment. So this is an example of target optimization. So this is what we do when we're either taking the patient's own brain MRI or a template, based on their age, and we decompose the MRI and basically use software to program how to configure sensors in order to hit the target that we want to hit. So if we're trying to kind of deactivate, for example, the amygdala, we have to go through the temporal cortex to get there. There's other ways to get in as well. And this gives us a simulation of what we're likely to see in the neurophysiological response of the patient's brain. So it helps guide us. And of course, during the treatment, we collect our own electrical neuroimaging data to make sure that we're, hitting the target and manipulating the target in the direction we want to. So this slide is asking the question, so when combined, it's similar to what we asked earlier, doing multiple diagnostic assessment, does it ultimately improve outcome? Well, this slide is asking the question, does combining treatments improve outcome? And this is a complicated question. Been a lot of literature written about these types of answers, and a lot of studies still going on today. And there's just so many variables. So for certain types of disorders, yeah, combining treatments are absolutely necessary. For example, schizophrenia. So the disorder matters in terms of whether you need to combine treatments or not. The severity of the disorder matters in terms of mono treatment versus multiple level treatment. Different layers of psychiatric disorders as well as other comorbidities like in health disorders, that also determines if single therapy or combination therapy is going to be needed. So I think it goes back to what we talked about earlier, that if you have on the diagnostics assessment evidence that there's abnormalities or deviations in multiple layers or multiple systems, then yes, I think combining treatments is probably going to be a better way to address those multiple layers and probably improve patient outcome. So the best way that we determine did treatment work and if it did, by how much, is just reevaluation. So for example, we'll do the baseline assessment as I showed showed you earlier in the presentation, your psychiatric exam, your cortical functional assessment, autonomic nervous system assessment, psychological testing, etc. Diagnose the patient, and then depending on what we were treating, we're going to reevaluate those symptoms and deficits in a reevaluation. So, typically treatment doesn't take long. If we do, 4 weeks of treatment, let's say a combination treatment, then after that treatment, we're going to do the reevaluation, and we're going to know how much that patient improved and then where to go from there. So hopefully that gives you some insight into some of the diagnostic tools that are used at the Neuropsychiatric and Mental Health Center, some of the different treatment options, and how we tend to approach, patient care. So thank you for your attention, and hope to catch you at one of the next presentations. Thank you.